Hello everyone, my name is Lauren Huff, and today I'm going to be reviewing the analysis of a local clinic's compliance rate for screening for type 2 diabetes. The leading cause of death globally is cardiovascular disease. Associated risk factors with cardiovascular disease include obesity, smoking, hypertension, diabetes, and hyperlipidemia. These risk factors are modifiable. Diabetes affects approximately 30 million people, or 9.4% of the United States population. Of these 30 million individuals that are affected, an estimated 7.2 million have not been diagnosed. Obesity affects 1 in 3 adults, and as we mentioned earlier, is a modifiable risk factor associated with cardiovascular disease, along with diabetes. It is currently recommended that patients that are obese are being screened for type 2 diabetes by their primary care provider with a hemoglobin A1C, a glucose tolerance test, or a fasting blood glucose level. Screening for the population is recommended by the United States Preventative Task Force for patients that are between the ages of 45 to 70 years of age and that are also obese. The purpose of this study was to determine the compliance rate of screening for type 2 diabetes according to the U.S. Preventative Task Force recommendation in a rural primary clinic located in Forest City, Arkansas. The primary objective of this study, once again, is to determine the compliance rate of completing a screening for type 2 diabetes via an A1C reading in a rural primary clinic. Analyzing the clinician's screening compliance rate will allow for practice changes by the clinician to improve screening rates if needed. As these screening rates are improved, the overall health outcomes of the patient population will benefit. In completing this analysis, an IRB was obtained through Arkansas State University. The study was conducted using a retrospective chart audit, and this chart audit included 50 charts that were reviewed through an EMR in the primary clinic. The total population seen between September 1st and November 1st of 2019 was analyzed. The data collected included age, sex, race, current BMI, and if the screening had been completed. Sample population information. The inclusion criteria for this analysis included male and female patients that were between the ages of 45 to 70 years of age, that also had a diagnosis of obesity, and had a procedure code for an A1C screening completion. Exclusion criteria for the sample population were those patients that were less than 45 years of age or older than 70 years of age. If the patient already had a diagnosis of diabetes, they were not included in the analysis. And patients that did not have a diagnosis of obesity listed were not included in the data analysis. In completing the data analysis of the 50 charts reviewed, 38% of this patient population had an A1C screening completed. This rate of screening is lower than the rate that was analyzed by the United States Preventative Task Force. That rate was at 50%. The findings of this analysis show that there is room for improvement in the screening rate at this local rural clinic. As clinicians increase the screening rate, early diagnosis can be made. An earlier diagnosis leads to earlier education, improved health outcomes for the patient, and a decrease in the overall cost of health care. An interesting fact that I was able to note in reviewing the data analysis was as these screenings were completed in the 50 charts I reviewed, those that had an A1C completed were able to have a new diagnosis noted in 4 patients. Once again, as an earlier diagnosis is completed, the patient is able to have earlier referrals for a diabetic educator, podiatry if needed, and endocrinologist to assist and collaborate with the primary healthcare provider in managing these patients with a type 2 diabetes diagnosis. Thank you.